Now let's look at the potassium-sparing diuretics, which can be remembered with the mnemonic, the K stays. The stays stands for spironolactone, triamterene, and amiloride. Now there's no letter in the K stays mnemonic for eplerenone, but the way it can be remembered as a potassium-sparing diuretic is that it has the same mechanism of action as spironolactone. So spironolactone and eplerenone block the aldosterone receptor, and they're competitive antagonists. And triamterene and amiloride have the same mechanism, and that is that they block the sodium channel in the cortical collecting tubule. So here's where these potassium-sparing diuretics act, both spironolactone and eplerenone, as well as triamterene and amiloride. They're acting in the cortical collecting tubule. The clinical uses for the potassium-sparing diuretics include hyperaldosterone, which makes sense for spironolactone and eplerenone, but they also make sense for triamterene and amiloride because they're blocking that excess sodium reabsorption. Obviously, when you need diuretics in potassium-depleted patients, you're going to use potassium-sparing diuretics. And lastly, we're going to use potassium-sparing diuretics in CHF patients to prevent potassium depletion. And toxicity is going to include hyperkalemia, and spironolactone has some anti-androgen effects such as gynecomastia. So be careful with spironolactone because it can cause gynecomastia. Okay, let's take an overall look at the effects of diuretics on electrolytes. First, let's look at urine sodium chloride. Now, all diuretics are going to increase the excretion of sodium chloride in the urine except acetazolamide, which is a carbonic anhydrase inhibitor. And the reason it's not increasing urine sodium chloride is because it's increasing urine sodium bicarbonate excretion. Urine potassium is going to be increased with loop diuretics and thiazide diuretics, and obviously it's not going to be increased with potassium-sparing diuretics. Blood pH is decreased with carbonic anhydrase inhibitors. Now, why is that? Because they're increasing the excretion of bicarbonate. And because bicarbonate is a base, that's going to make the blood more acidic. Potassium-sparing diuretics also decrease blood pH. Why is that? Aldosterone inhibition prevents hydrogen ion secretion. Remember that aldosterone activates the secretion of hydrogen ions into the urine. And so when you inhibit aldosterone, it's going to lower blood pH. And hyperkalemia, which the potassium-sparing diuretics tend to push the body towards, also leads to potassium entering the cells. And when potassium enters the cells, hydrogen ions exit the cells. And both mechanisms, the hydrogen ions exiting the cells as well as aldosterone inhibition, will lead to decreased blood pH. And lastly, loop diuretics and thiazides increase blood pH. Firstly, this is due to volume contraction, which is going to lead to increased angiotensin II levels, and that will activate the sodium-hydrogen exchanger in the proximal tubule, and that's going to increase the excretion of hydrogen ions and therefore increase the blood pH, making it more alkaline. Secondly, potassium loss from the cells, because loop diuretics and thiazides will increase potassium excretion. The decrease in potassium in the blood will lead to potassium exiting the cells. And so as potassium exits the cells, hydrogen ions will enter the cells. Just like we saw with the potassium-sparing diuretics, where when potassium entered the cells, hydrogen ions exited the cells. So here, with loop diuretics and thiazides, we're getting the opposite effect. And with hydrogen ions entering the cells, we're getting a more basic pH. And finally, in a low potassium state, hydrogen ions are exchanged for sodium in the cortical collecting tubule. So, in our cortical collecting tubule, as sodium is reabsorbed, hydrogen ions are going to be secreted instead of potassium. So potassium won't be secreted, it'll be the hydrogen ions. And that is because when sodium is reabsorbed, it's creating that negative lumen potential and pulling in positively charged hydrogen ions. And all three of these mechanisms, 1, 2, and 3, are leading to increased blood pH due to loop diuretics and thiazides. And urine calcium is going to be increased with loop diuretics. Remember that loops lose calcium, and so calcium will be excreted in greater quantity in the urine. And thiazides decrease urine calcium concentration, and this is due to the increase in paracellular calcium reabsorption. So, thiazides will decrease urine calcium excretion. The final class of drugs that is relevant to the kidneys is the ACE inhibitors. All of these drugs will end in pril, and that's how you remember it. They function by reducing the levels of angiotensin II. And how do they do that? They're inhibiting ACE, angiotensin converting enzyme, which converts angiotensin I to angiotensin II. Now, what converts angiotensinogen to angiotensin I? That's renin, remember. This is all part of the renin-angiotensin-aldosterone system, the RAS system. So, with reduced angiotensin II levels, this is going to have a number of distinct effects. And first, it's going to cause efferent arterial vasodilation in the kidney, which is going to reduce GFR as long as the afferent arterial remains the same. And it's going to increase bradykinin levels, which is a potent vasodilator. So clinical uses for ACE inhibitors, the first of all obviously is hypertension, but they're also used in heart failure because they prevent cardiac pathological remodeling, which severely reduces the pumping efficiency of the heart. And in diabetes, they slow down the chronic kidney damage seen in diabetic nephropathy. It's especially going to have a protective effect at the efferent arterial. Because remember that we saw when we studied diabetic nephropathy that there's non-enzymatic glycosylation in that efferent arterial. And this is reduced with the efferent arterial vasodilation because there's less pressure being exerted on the walls of that efferent arterial. They're also helpful in proteinuria because they're going to cause vasodilation of the efferent arterial, and there'll be less pressure in the glomerulus to drive proteins through the glomerular filter into the filtrate. Now, side effects of the ACE inhibitors are often the things that prevent them from being used, and they can be remembered with the mnemonic CATCH. The most common is cough, and it's caused by the increased bradykinin levels. The other side effects are angioedema, which is especially problematic in patients with C1 esterase inhibitor deficiency. And ACE inhibitors should not be used in pregnancy because they're teratogenic. They also lead to increased creatinine levels, hyperkalemia, and hypotension. Also, as a side note, a newer class of drugs called angiotensin receptor blockers work similarly to ACE inhibitors, but they act by directly blocking the angiotensin II receptor. They're not preventing the production of angiotensin II, they're actually working at the receptor and blocking the receptor. So, what side effect will these drugs avoid? Well, since they're not going to affect the angiotensin converting enzyme, they're not going to cause increased bradykinin levels. So, this will not happen with angiotensin receptor blockers, so they don't have that nasty side effect of cough, and they're a great alternative for patients who can't tolerate their ACE inhibitors because of a cough. Okay, let's finish up with some questions. A 56-year-old man comes to your office for blood pressure follow-up. He currently takes furosemide daily. His blood pressure is 145/98 and his serum potassium is 2.9. Which of the following drugs would make the best addition to his regimen? Hydrochlorothiazide, triamterene, mannitol, or acetazolamide? If you said triamterene, you're right. All of the diuretics that were mentioned can be helpful in lowering the patient's blood pressure, but he was hypokalemic. He had a potassium of 2.9. And triamterene was the only diuretic that is potassium sparing and will increase his serum potassium at the same time lowering his blood pressure. So, two birds killed with one stone. One more flash quiz. An 82-year-old man with a history of multiple myocardial infarctions presents to your office with peripheral edema. Lung exam reveals bilateral crackles and neck exam shows distended veins. In the acute setting, which of the following drugs is most indicated? Lisinopril, furosemide, or spironolactone? The answer here is furosemide. This time, the patient is in acute heart failure, and he needs a strong diuretic to remove fluid. Furosemide is much stronger than spironolactone, and as a side note, lisinopril is useful in chronic heart failure because it is an ACE inhibitor. So it's good in chronic heart failure. And remember, it's preventing that pathological remodeling. But it's not that helpful in the acute setting when the goal is to remove fluid in this patient, which is what we saw with the crackles and the edema. Okay, one last question to test yourself. A 45-year-old man presents to his primary care physician with a blood pressure of 160/90, and it has failed to drop substantially after initiation of lifestyle changes. He has no medical history and takes no medications. The patient is subsequently given an antihypertensive medication. On a follow-up appointment, his laboratory results are sodium 133, potassium 5.4, bicarbonate 33, glucose 166, urine calcium 50 milligrams in 24 hours. Which of the following represents the site of action of the medication he was most likely given? The correct answer is B. This patient presents with metabolic alkalosis. See the bicarb? It's high. That's metabolic alkalosis. As well as hyperglycemia. and the patient's urine calcium is lower than normal. And all of these are common adverse effects of thiazide diuretics. Remember that thiazides inhibit the sodium chloride cotransporter on the luminal surface of the distal tubule by binding to the protein's chloride site. So they're blocking the sodium chloride cotransporter. And this is in the early distal tubule. So the correct answer was B. Now let's look at why the others were not correct. A is not correct because this describes the site of action of ADH, which causes the insertion of aquaporin channels in the collecting duct. C is not correct because this describes the mechanism of carbonic anhydrase inhibitors, and these would lead to metabolic acidosis, not alkalosis. D is not correct because this describes the site of action of the potassium-sparing diuretics, and this would not affect the urine calcium concentration. And finally, E is not correct because this describes the site of action of the loop diuretics, which block the sodium-potassium chloride symporter in the thick ascending limb of the loop of Henle. Now, loops cause a metabolic alkalosis like thiazides, but they cause increased urine calcium concentration. Remember that loops lose calcium. Great job. That finishes up the renal chapter and my time with you. My advice is to focus on understanding the concepts before you focus on memorizing the details, and you will maximize your potential for success on the exam. The USMLE Step 1 is an important exam in every medical student's life, so give it your best and have no regrets. There's an old Arabic saying that goes, لا يؤتيك العلم بعده حتى تؤتيه كلك, which translates to knowledge will not give you a part of itself until you give it all of yourself. So give this test your entire effort, and we'll be waiting for you on the other side. Happy studying. Peace.